Good morning, everybody. I think that's the first time I've ever had a soundtrack. And I have to say, I kind of like it. I may have to work on this. It's been an inspiring morning. I've been amazed at the passion that's been gathered here. We certainly need it. And it's also a very exciting time when it comes to the discussion of patient safety, about preventing harm to patients. As you heard earlier, patient safety is something that's been a thing for over 50 years. Right? We've been working at this in fits and starts in different angles for quite some time. We're certainly not there yet. But I want to suggest that it's actually a very exciting time in this field. I've personally been in it for 20 years. And right now I see an amazing intersection of demand and capability. There have been many attempts to make things better. And some things we still struggle with, but I've seen some successes. I'll talk about a few things that are going well, and then I'll also share a number of challenges. So over the past several years, we have been measuring at CDC and pushing to reduce several healthcare-associated infections. Surgical site infections, invasive staphylococcal infections, central line-associated bloodstream infections. And we're seeing success. Why are we seeing success? A couple of things. First and foremost, we clarified what we want to measure, and we measured it and fed it back to the people who are doing the work. This is key. A second thing is we've provided tools that make a difference and make it easier to do the right thing every time. And we've targeted a handful of things. This is a small tip of a very large patient safety iceberg. But we've targeted things that we know we can change. And this is all very good. Hidden behind this graphic, though, is a very interesting change, and that's a cultural change. About 6 years ago, we started talking about eliminating healthcare-associated infections. And I can tell you that my colleagues in infectious diseases, my colleagues in hospital epi, certainly my colleagues in the C-suite of hospitals were mortified. The first thing they said was, you can't say that, right? We wanted to have a big conference and say eliminating healthcare-associated infections, and they said, no, how about towards elimination? Just a little step. Because they were afraid it would A, make them look bad, make them culpable, put them at risk for lawsuits. Understandable, but certainly not helpful. Not helpful to me as a doctor or as a patient. The striking thing that happened about 5 or 6 years ago, you heard Dr. Pronevost's name. I think Leah mentioned it. Peter Pronovost is a very dear colleague, and he had the very straightforward yet brilliant idea of taking our guidelines at CDC, which I confess are dry and somewhat bulky, and focusing them down into a very user-friendly checklist, right? Very easy to use, very effective. What we saw when we measured the impact of that was that infections of the bloodstream, which kill a lot of people, were reduced not by 5%, not by 10%, but by 70% with a sustainable improvement for years, okay? What does that mean? It means that by doing everything you knew you were supposed to do anyways, there's nothing earth-shaking or new here, but by doing the right thing the right way every single time, 70% of these potentially deadly infections could be prevented. That's an ethical indictment, right? All of a sudden, when you show people that you can do this just by doing things properly every time, there's no way to not do this and be legitimate. So this is where the conversation started to turn in the rank and file amongst clinicians saying, you know, we really should be talking about elimination. Now, let me talk about the word elimination, not the yucky elimination, but the good elimination. It's different from eradication, yes? Eradication is like smallpox. It's no longer on the planet, it's gone. Well, it's in a couple of small places. Or polio, we're trying to eradicate polio, so it's no longer a going concern. This is great. That's not what we're talking about. Elimination is like dust bunnies, okay? If you sweep frequently, you have no dust bunnies. But the minute you take a week off, in my house 3 days, dust bunnies come back. And healthcare-associated infections, patient harms, all of these are much more akin to dust bunnies than they are to something you can actually eradicate. It means it's not one and done. That's what makes it so hard. When things are one and done, you do one shot, you get it taken care of, and you move on to the next thing, that's pretty easy. You generate a head of steam, you get people on board, you apply the intervention, and you're good. With this, you have to maintain that head of steam day after day, year after year. I'll come back to this at the end of my comments, but I have to tell you, this is the biggest single challenge, maintaining that level of excellence. Basically, just to foreshadow, what we're asking for is for every patient interaction, right, for every hospital setting to be like a 3-star restaurant, yeah, where everything is perfect. Like I said, I'll come back to that in a moment. So what else is there embedded in this diagram? Oop, here we go. It's the fact that we need to keep pushing. So here, if you think about the fact that 70% of those central line-associated bloodstream infections were prevented, we know that we can get down to 70. Right now in the United States, our data show us that we're at about 40, maybe 45%, which means there's 25 to 30% more benefit that we can squeeze out of that proven intervention. So we have to. We spend a great deal of effort pushing on this, training people, sharing information. But we need to use all of what we've got in hand. Beyond that, what's the other 30%? It's different organisms causing the infection, right? Could it be yeast? Could it be resistant pathogens? Certainly. And it's probably not the insertion of the catheter that the checklist makes perfect. It's probably things like how you handle the catheter or what you put through it. And that's research that we do at CDC. It's different from, discovering the new vaccine at NIH. But CDC's applied research answers those questions so that we can then produce the next round of guidelines and then hand them to Peter, who can make beautiful checklists for us. This is the cycle that we use to tackle these issues. We're doing it in a non-static setting. This is something that I think you all are painfully familiar with. Maybe not always painfully, but it is a shifting and complex system. The arrows originally also have bidirectionality and crisscrossiness, but the bottom line here, so this is a very bizarre wide screen. I don't know if y'all know this, but normal slides are not this wide. Just trust me on this. So they very kindly reformatted for me. But the point I'm making here is that back in the day, medical care took place in hospitals, full stop. And so if you tackled the hospital, you're good. Today, we provide many more surgeries in outpatient ambulatory surgery centers than we do in a hospital, and yet the net number of surgeries is going up, right? Patients move back and forth between ambulatory facilities to long-term care facilities, back to hospitals. And when you look at this pattern, it means that we don't have an easy sort of single hit target. This is a great example of a very difficult to treat resistant bacterium, CRE, also referred to as the nightmare bacteria, in Chicago, showing that there was one long-term acute care facility in the middle of that diagram in the red dot that was acting as this concentration dissemination center, almost like the Amazon.com for this bacterium, which was then going through all of those blue triangles that are patients to myriad hospitals, acute care facilities, outpatient facilities, and so on. So this is what we've created. It's got tremendous benefit. I love the fact that one of my best friends just had his hernia fixed. He drove in, had it done, came back home, and is doing great within 2 days. Right? This is marvelous. My very dear friend in San Francisco who calls me and says, Mike, I have a patient, and I think, they might have had a skin test for tuberculosis last week, but I don't see a result. I'm supposed to do her larynx for her. Should I do the case or not? I'm in Atlanta, so the fact that she's having to call me was weird, and I'm like, no, you should ask the infection control professional that works with you whether that's been taken care of. And she says, Mike, it's me, the secretary, and the patient. This is an outpatient surgery center. I'm like, why do you work in a place like that? This is San Francisco, and she said, without missing a beat, parking, right? I can drive in, do my case, and get out. It's great. There are very good things about it. But it means that we might be missing pieces of infrastructure, and this illustrates that beautifully. So what else has changed? There is now this embraciveness towards elimination. I have colleagues from C-suites down to the front lines saying, yes, we want to do more, we want to get there, we want to eliminate these infections. Data. Data is a huge sea change. Data are a huge, for those grammar freaks, data are a huge, it's weird. Anyways, we started out back in the day collecting data from 300 volunteer facilities. It started out even smaller. These were academic centers of excellence that wanted to see how they were doing. But let me tell you, back then, not only were they faxing us hard copies, which we then entered, but we were also having to give them assurances that even under the threat of a lawsuit, their data would be completely protected. None of this information could, quote, get out, because heavens forbid someone heard that this hospital had an infection, right? So that was the prevailing culture until about 5 or 6 years ago, and a wonderful thing happened. We started to partner with the Centers for Medicare and Medicaid Services, and this is driven by what Joel Hoyt mentioned. The work he did in policy at the federal level to say that CMS will start paying for quality, CMS will not pay for adverse events, included having CMS come to us and saying, all right, so this quality thing, what should we be measuring? What should we track? What should we require? The conditions for participation in CMS now include CDC guidelines. In the past, they were helpful suggestions, and today they're part of the way we do business. Amazing thing. Another thing that CMS did for us was require every facility to submit data to NHSN. So not only do we have all 5,000 of the acute care facilities in this country, not including critical access hospitals that get a special pass right now, we have nursing homes, we have all the dialysis facilities, we have long-term acute care facilities, and it's a wealth of information. We've gone from having a little snapshot from which we calculate an estimate to being able to actually count. And then these data go back to, on the far right there, CMS. So on the Hospital Compare website, you can get specific hospital data. This is no longer just about making summary statements available from a regional or state perspective. This has the names and addresses of facilities, and it gives you their infection rates. We share the same data and help analyze it for Consumers Union. Incredible partnership with patient advocates. This has been another major change in how we do business. State health departments, you see Oklahoma and New Mexico in the middle here, are using these data to track their own success. And why is that important? Because they're the regulators, right? You've heard about well, just now, I think Leah Binder mentioned a need for something like, or maybe it was Michael, a grade put up for healthcare facilities like we do for restaurants. Well, we're getting close. State health departments now can do that. Increasingly, excuse me, local health authorities also are tying things like business licenses for outpatient clinics to performance and assessment. I'll come back to a specific on that in just a moment. Also related to this is the use of data in a very real-time way. If we go back 10, 12 years, we were taking a cumulative summary of data, publishing it once a year, taking a year to analyze it before then, and it was of academic interest. There's this thick report that said, yep, there were roughly this many of these and that many of those. That's not very easy to act on. What we're doing now, because we have complete coverage of every facility that's being reimbursed, we're able to do frequent analyses and look for hot spots, basically. And we do it two ways. We look for places that are having a high number of fill-in-the-blank infection, CLABSIs, and then we also look at how, quote, significant they are, in that if we have a hospital that has a high percentage of infections related to a catheter, but it's a tiny little hospital that might have 2 catheters in a given calendar year, that's not where the impact is likely to be the greatest. When we see a major center that has tremendous throughput of patients, lots of catheters, even though their rate might be smaller, the net harm that that's causing is much more significant. And so now we call them, right? We do these analyses. They're targeted assessment for prevention TAP reports that we use. We call them, and the hospital gets a call from CDC saying, hello, you may not realize this, but it turns out that not only your hospital, but this unit, this one intensive care unit, is having a notably high rate. In fact, a great example when we first started doing this was in Tennessee. We found that on the western end of the state, there were 2 units that were accountable for the high rate of the state overall. When we talked to them, we said, this is not punitive. We're not here to shut you down. We want to make things better. Can we send a team? We worked with the state health department. Tennessee has one of the preeminent health departments when it comes to healthcare safety. And they sent people to come with us. We went to the units, we trained, we did remediation, we improved practices, and boom, the next year those rates went down. The entire state looked better. So this is a very different and frankly refreshing way to use data. It is no longer an academic exercise. It's what can we do to actually change something and make it better now. Now the troublesome bit. In the process of doing all of this, I wish I could tell you we were focused purely on the cutting edge of improvements, improving the way we do surgery, improving the way we manage central lines, that kind of thing. But at the same time, we get repeated outbreaks of, for example, hepatitis C because clinicians are reusing needles and syringes. In this day and age, you would think it would be a resource-limited, remote, jungle-type problem, but it's happening in every community around this country. Across the country, we see nurses, anesthetists, physicians thinking that it's okay to reuse a syringe. I scared the heck out of our press people a couple years ago when I basically said on camera, is this greed, stupidity, or laziness? Because those are really the only choices, right? Are you trying to save a penny by reusing the syringe? Are you too lazy to walk down the hall to get another one? Or are you so incredibly stupid that you don't understand that this is going to happen? And it's a huge challenge. We do a great deal of work trying to turn the tide of this. Amidst all of the sort of progressive, exciting stuff, we are detailing healthcare providers essentially nonstop to get the message out. And similarly, we're working with patients so that individuals have a sense of, what is it that I need to be afraid of? What is it that needs to concern me? We don't want free-floating anxiety, but we do want the assertiveness that you heard about this morning. I think that's a great word. But I'll tell you, it's hard. My own mother died of a hospital-associated infection after surgery. And as the lead guy who writes the guidelines, who does this for the country, I'm in the room in the intensive care unit, and yes, I spoke up, but it wasn't easy. I stood there thinking, am I going to piss off this nurse who's going to be here alone with my mom late tonight? Do I really want to do that? It's a very challenging thing. It's also hard when you're personally in the middle of something, right? If you're there receiving a cancer diagnosis, really, are you going to have the presence of mind to ask defensive questions? Probably not. So, there's a need to rethink how we do this. When we talk about assertiveness, it's a systems issue. One way to do it, I encourage patients to bring a friend, a family member, a partner, whomever, to sit there tasked with a list of questions, right? Is that vial a new vial that you're about to use? Has it ever been opened? Are you using a fresh syringe? How often do you clean that? And just, side anecdote, I was in my clinician's office for a routine checkup a couple years ago, and I'm sitting there, and I'll be totally honest, I'm terrible, classic physician. I hadn't been to the doctor for 25 years, literally. And I hit a certain number, and I thought, okay, maybe I should do this. And so I go, and everything was fine, but I'm sitting there, and I look at the hand soap dispenser, right? It's the liquid green soap. And on top, there's this thick, leathery scum, right? Which obviously has not moved in years. And she sits down, and she's very nice. And I'm like, Dr. Nan, I just have to say this. That is so wrong. You can't do that. And she turned scarlet and apologized. And sure enough, 2 weeks later, when I went back to pick up test results or whatever it was, they were all brand new. They were all beautiful. And she dragged me in to show me. But there's a lot to think about. There are a lot of details. And when it comes to that assertiveness, I wonder what we need to create in terms of an ombudsperson. What is it that we need to install at the bedside, near procedure locations, that will take the place of the individual or a family member having to play that role? Should there be professional oversight in patient care? I'll share one other personal anecdote. A very dear friend of mine passed away last year after struggling with pancreatic cancer. I spent weeks in the intensive care unit, sitting there, having conversations, chatting, just being there. I was in civilian clothes. I looked completely nondescript. I tried not to be obnoxious. And I watched incredibly good-hearted nursing staff trying to do a good job when alarms are going off at opposite ends of the hallway. They're a little short-staffed. They need to get all of these medications hung on time, and then there's a shift change coming up, right? It is a scramble. And what do I see when this kind of thing happens? I see an oximeter alarm go off, somebody's suctioning, they've got gloves on, there's sputum, and they turn the alarm off, they finish suctioning, they take their gloves off and wash their hands. There's now sputum on the alarm button. Does anyone clean that? No. Housekeeping doesn't. Central Supply might when you send it back, right? But there's no attention to that little spot of phlegm. And so the next patient is there, doesn't have that bacterium. The alarm goes off again, gloves, and there you have it, you've just spread infection. This is a chaotic system. This is not anyone's fault. But I see this kind of thing happening. Clean linens being carried, and a patient says, "Excuse me, can you help me with my IV?" Right? That's important. The nurse puts the clean linens down on top of the waste can that has a lid, right? Goes and helps the patient, picks them up, and goes to wherever he or she was going. That waste can should have a pointed top, frankly, right? And frankly, this is a good thing. Mechanical ventilators. When I started training, they were big things that looked like refrigerators with a very irresistible surface on top, right? Everyone put stuff on top of the ventilator. And now they're a flat screen with a little skeleton frame, and you can't do that. This is great. There are no longer knobs, which means that housekeeping can actually wipe down the surface. Again, we're making progress, either intentionally or otherwise, but I see these as hints to what we need to be thinking about when it comes to innovation. One other major challenge that I'll share with you, just to give you a sense of what keeps me up at night. Antibiotic resistance is something that we've all heard about plenty of times, and I think we all nod and say, yes, it's bad, we should use antibiotics responsibly. And yet, it's a challenge. It's kind of like the CT scan that you heard about moments ago, only it happens a lot more frequently, right? Everyone comes in, has the sore throat, needs to get back to work by Thursday, and so wants an antibiotic just in case. The word Z-Pak gets used very frequently in this country. Brilliant marketing approach, just for the record. But it's something that we have a major sort of systematic challenge in controlling. And yet, where are we today? We now have untreatable organisms, right? It's one thing to have an untreatable organism if it's something that just colonizes you. So if I have a very resistant staph bacterium, MRSA, I can have my nostrils treated with ointment. I can bathe with chlorhexidine soap for 3 or 4 days before I have a procedure, a surgery on my chest, and I can really reduce the risk of causing a staph infection from my own flora. This is great, but what are we talking about now? We're talking about carbapenem-resistant Enterobacteriaceae, which is fun to say. CRE includes organisms like E. coli. It's bacteria that we have to have in our guts in order to be healthy. If we lose them, we become even sicker. So we can't get rid of these organisms, but when some proportion of them are resistant to all antibiotics, there are some very direct consequences. And we've seen these in countries where over-the-counter antibiotics have been common for a while, Brazil, for example. So right now, if someone comes to my office in the middle of the day and says, look, I think I have a bladder infection, can I get some antibiotics? I do a quick test, say, yes, this is probably a bladder infection, write a prescription. You get it filled on your way back to the office, and you're good to go. Probably by the next morning, you feel fine. This is great, and this is what we want. When there is a significant and growing chance that the organism causing that infection is not going to be treated by this prescription, this oral drug, I can't take a chance that this is going to lead to a kidney infection, a bloodstream infection, and sepsis if I just let you walk away with that piece of paper. So then what does that mean? It means waiting for a culture, and then I need to treat you now, so then getting a PICC line or some other IV inserted and getting you started on an intravenous drug. Okay, your afternoon is shot, right? Probably your week is shot, and the cost, talk about change in expense between a $7 prescription and, you can tell me better than I can tell you what that costs for infusion care. So that's something that we're looking at when we talk about untreatable infections, but it gets worse. Right now, if I get hit by a bus and my belly is torn open, talented emergency medicine docs can resuscitate me, great surgeons can sew me back together, but the road grit, the bowel flora that get into my wound are going to cause an infection. That's going to happen. I rely on an antibiotic to clean that up so that I can survive the injury. Similarly, if I need care for, say, cancer, right? Chemotherapy is amazing stuff, but it kills your ability to fight off infections. What do we do right now? We track people for fevers, and the minute there's a hint of an infection, we hit them with a broad spectrum of antibiotics so they don't die of sepsis. The same thing is true with stem cell transplants. When we give you whole body irradiation, right? You are shut down for a good several weeks or months. And until you're better again, you need antibiotics. Well, if you don't have those things, the ethical balance between saving your life and killing you shifts dramatically, right? Infections are serious things. We forget that. Most of us in this room grew up in an era where we can actually just assume antibiotics were there to help us. But go back to a great-grandparents' generation where a hangnail on the farm could lead to, have you heard the phrase blood poisoning? Right, where the red streak goes up your arm till it hits your heart and kills you. That's what I was taught when I was a little kid. Well, that's an infection that's spreading, right? And that's why people back in the day were obsessed with mercurochrome and tincture of iodine. You got to put something that burns on the wound because God forbid you get an infection. How often have you seen mercurochrome and iodine these days? Never, right? It's not even out there on the grocery store shelves anymore. It's fascinating to me how much we've kind of decided that we don't need to worry about infections, and yet they're coming back. So antimicrobial resistance is something that is not only on the horizon, it's actually here. We have about a 10-year gap between now and the next major release of a new antibiotic. The pipeline is pretty darned empty. And every single antibiotic that's been produced to date has actually had resistance generated within a year. So this is something that truly scares me. And it's not just infections of the skin or the belly. Think about tuberculosis. There are essentially untreatable strains of tuberculosis, and that's a bacteria that doesn't require a car accident. It doesn't require chemotherapy. People sharing a room like this, if one person in back is coughing and spraying out tuberculosis bacteria, we can all become infected. There isn't a good vaccine. And if there's no treatment, we go back by 80 to 120 years where consumption, think La Boheme, is killing people left and right. That was a very classy reference, just for the record. I just have to say. So, that said, this is something that is very real. It threatens our way of life here in this country and is already killing people in other parts of the world. The federal government, fortunately, is taking this very seriously. It includes opening the door to pharmaceutical industry to say, look, if you will dive in and do this, really, it makes no sense to develop a new antibiotic in this era, right? You spend millions of dollars trying to find one, more millions of dollars getting it through approval processes, and then I'm out here saying, but don't use it too much, right? This is not profitable. And anyone who uses it only uses it for a couple of weeks. And within a few years, resistance rises and it's useless again. Makes much more sense to focus on my hairline or any other chronic condition that is going to really reimburse that investment. So the federal government is looking at ways to sweeten the deal, make it easier to get drugs through, make it less expensive to develop, and at the same time we're continuing to lean on not only healthcare delivery, but on patients as well, to think again about what they want when it comes to antibiotics. I'm going to spend the last 10 minutes or so talking about this. I'm very excited that you're all here today because of the intersection of people that this conference has brought together. I can spend plenty of time talking to clinicians, but that's kind of like talking to a pilot saying, you should make sure that your airline has no crashes. Well, she doesn't actually have that authority, right? She doesn't control the system. A lot of people are involved in that system. The same thing is true for healthcare. And so the fact that we have innovators, we have decision makers, we have payers and purchasers, this is marvelous. What am I asking for? I talked about 3-star restaurants. Those are 3 Michelin stars, so the other 2 don't exist, right? I don't think we want it yet, we writ large. I want us to want perfect care. I want every interaction with every patient every day to be perfect. Now, we're talking about creating something audacious. This is bigger than the space program. In my opinion, it's harder than getting to Mars. okay? I'm not asking for something light or easy or cheap. I'm asking for something huge. Mars is kind of easy, right? You build a fabulous rocket, you get it up once, cross your fingers, and it'll probably get there. We're pretty good at that. But there's no one else involved. Your engineering team and the device is all it takes. Here we're talking about such a complex system, not only in terms of locations of care, but the fact that you have everything from highly trained clinicians, right, clinical staff, pharmacists, that's good, but then not so highly trained ancillary staff who are often contractors, may speak a different primary language, may be turning over at a tremendous rate. This is a challenge. May be afraid of pointing out a problem because their job is on the line. They don't want to make waves, right? We're dealing with independent clinicians who practice in a small office. I still get the willies thinking about, 20 some years ago, 30 years ago, when I was doing procedures in an office, right? I was a young physician sewing up wounds. It was great. Was there any oversight? Was there anybody looking over my shoulder, asking about quality, asking about hygiene? Zero. And that's the reality in the vast majority of independent settings today. One of the conversations we're having with local health authorities is, how do we bring more oversight and assurance of competency to those settings where there is no systematic way to look, there's no systematic way to improve? This is one of the additional challenges that we have. Lastly, we're also looking at migration of acuity, right? Back in the day, the patients that are on a normal hospital ward right now would all have been in the intensive care unit with greater staffing, greater attention. But we've gotten better at a lot of things, and we've moved them out to the wards where there's less staffing, less oversight. A lot of patients that would have been on the wards 25, 30 years ago are now in long-term skilled nursing facilities. And some of those skilled nursing type jobs are now in nursing homes. And what do we see from that? We see outbreaks of hepatitis because in the nursing home, somebody whose last job was probably at McDonald's is saying, oh, there's this great little injector for insulin. It's so handy. I just click it and put on a new needle and use the same reservoir. Well, that's an individual device, right? That's a personal use device, an insulin pen. But it's so handy. Why not just right down the hallway, go give everybody their morning insulin? And that's what happens, and we see hepatitis outbreaks, right? This is the challenge that we're working with. There are so many people involved in making sure that everything goes right. But at that initial clinical interface, what I'm hoping is that we can engineer a system where perfection is attained every time, okay? I'm not talking about trying to convince my patient that having your Cocker Spaniel lick your surgical site is a good thing. I've had that more times than I can tell you because dogs' mouths are cleaner than humans' mouths, et cetera, et cetera, et cetera. I can't control that, right? We can't. I've had plenty of lung patients who continue to smoke, heart disease patients who, tuck into a steak. I had a patient tell me when they said they were giving up meat the last visit and they put on 3 pounds. I'm like, so what did you do? You said you're giving up meat. He's like, yes, I now just eat pork. I'm like, oh. So we cannot control the reality of human beings, but we can talk about systems engineering. We can talk about human factors. We can talk about sort of systems for training and competency. Why isn't perfect care part of nursing and medical curriculum? We spend a ton of time right now talking about molecular diagnostics, about innovative therapeutics, and this is great. We need that. But somewhere in there needs to be a core. And that core, whether it's microbiology, which is down to 3 or 4 days, used to be 3 months, just so you know, it's gone. When we talk about hygiene and infection control in nursing curricula, it's essentially non-existent, right? And yet that's the thing that our safety hinges on as patients. So there's a need for training. There's a need for retraining, right? There should be requirements. Just like we have continuing education credits for licensure. California was able to say pain control needs to be part of that curriculum. I sat through, I can't tell you how many hours of training, learning about pain control in palliative care, just because the state of California said, you've got to do that to have a license. Well, okay, let's do it for this too. Let's do it for several things. So the training is important, and then certifying competency, yes? I can't guarantee that competency certification is going to be everything, but it's like a driver's license. I want every kid out there starting to drive to have passed the test and showed that they can, do the basic maneuvers. Does that mean he or she is not going to go out and have an accident? No, but it's better than the alternative. And right now we don't have that, right? So making sure that clinical staff have that added due diligence. Oversight, we've already talked about grading restaurants. If we can do it for restaurants, I think we can do it for clinical care settings, but the metric is hard. Leah Binder mentioned very, very clearly that it isn't easy to say that if you're good at this, then you're good at everything. We do need a reliable metric, and I think we're getting there. A lot of work that Leapfrog has done is building a powerful foundation there, and I think we should move in that direction. The fact that it's all now public is great. Helping the public understand what they're looking at is the next step, right? It's mysterious. There's a lot of data out there, but it's a table full of numbers. One of the reasons we partner with Consumers Union is because they're able to translate that into the black dot, the half a black dot, the red dot, yes? That's what I want. I want people to be able to look and say, not only this is where I want to go for my care, but also here's the intelligent question. If you're going to be my primary care doc, where do you have privileges? And why are you in the crappy hospital? You're a nice guy, but if you're going to be at the crappy hospital, I want to go over here. Can you get privileges there? Otherwise, I'm going to have a different doctor, right? In particular for things like surgery. So there's that issue. And then there's the fun stuff, environmental interventions. What are we relying on right now for things like Clostridium difficile? C. diff is a diarrheal disease, killer diarrhea. It obtained a toxic element about 20 years ago. And just for the record, it came from Canada, it came from the north. We watched it spread, but it's now pretty much pervasive. And it's so much worse than what it used to be. So now, if I take antibiotics and I wipe out my colon flora, I can actually get Clostridium difficile diarrhea. Back in the day, it was antibiotic diarrhea. It was a nuisance, but it went away. Today, because of the toxin, it turns your colon into hamburger, right? So that, the scenario that's just dreadful, an 80-some-year-old slips, breaks a hip, and goes in, has a successful hip replacement, hooray. But in the intensive care unit, has a catheter in and gets a little bit of a bladder infection, gets put on antibiotics, and now has C. diff. It gets bad, has her colon removed, and now, instead of going to the nursing facility for a little bit of rehab and back home to be with grandkids, she's not likely to make it out of the intensive care unit. Right? This is what we're talking about, and the rates are huge. Right now, we rely on usually contractual workers that are not very well paid to clean rooms on a daily basis in between patients. Right? Explaining to each individual every time they turn over what's wanted is not happening very systematically or very well. And it may not be the battle that we want to fight. There are devices that are out now. Many facilities are testing them, they're trying them. We're trying to accumulate data so that at the federal guideline level, I can write a recommendation that says every facility should use this type of thing, right? Not necessarily a proprietary recommendation, but whether it's vapor-phase hydrogen peroxide generators or ultraviolet flashy flash robots, there are multiple technologies that are in the works on the cusp of being usable. They have challenges right now. UV requires a fairly direct line of sight to be effective. The peroxides, the vapor is nice, it gets everywhere, but it takes a couple of hours to dry out. And when you've got 17 people in the hallway of your emergency room trying to come to the hospital, that extra time for room turnover is unacceptable. So it's not completely mature yet, but we will get there so that all of a sudden, one of the vendors uses the phrase a hotel clean. Now you're asking your workers to do a hotel clean so it looks nice, the pillows are plump, everything looks pretty, there's no goobers anywhere. But the actual dealing with invisible pathogens, right, which requires complete meticulousness, is off the table, right? The thing comes in, does that part of it, and now you've deburdened the environment. So then, even if I'm a very clumsy healthcare provider and I touch something and I touch my patient, I'm less likely to deliver something bad. So there's that kind of technology. We're looking at innovations with regard to treated surfaces, different surface textures, different materials that can reduce the ability of organisms to survive in the environment. So the environment is there as one piece. And then there's facility design. There has been no improvement in facility design from a quality/infection control perspective for generations. I still walk the gauntlet of people coughing in a waiting area as I go into an emergency department or a clinical space, right? What's up with that? During SARS, people said, hey, stay in your car, you have a cell phone, I'll call you, right? Come in one at a time. We do it at the Cheesecake Factory, for God's sakes. So, with that in mind, why aren't we thinking about this for medical care? It probably makes a lot of sense. I'm also talking with innovative vendors about temporary computer-generated customizable barriers so that if you decide in this flu season we want to use only that hallway, you can get these self-supporting things that are CAD design, you hit print, a machine spits them out, they go up, and you're good, and your net investment is tiny, as opposed to calling your carpenters to come in and put a temporary wall. So there are things like that we can talk about. And then my last one, and this is a desperate ask, is the electronic health records. You heard about how long ago they were started. You heard about, and you've seen every day, how limited the interactivity is. But it's not even just interactivity. We'll get there, right? We're working with the standards groups. We are working with specific vendors as a community to try and integrate and make things easier to be plug and play. But that's not the issue. That's one issue. The underlying issue that no one talks about is why these systems exist, why they're purchased, and what they're really good at doing. They're really good at billing. I'll be very honest and slightly cynical and say that the reason these things get purchased at great expense and maintained is to make sure that not a single billable dollar gets lost, right? Hospitals are desperate. We can't afford to lose anything. I challenge the health informatics world to think about what would an electronic health record look like if it was designed to make me, as a clinician, a better clinician. Right now, my clinician has to go, if she's trying to document swollen ankles because of heart disease, she has to go into the orthopedic section and scroll down to ankle. And this is a brand new system that just got installed. This is absurd, right? Where is the focus group of clinicians who say, I've made this error or I've had this challenge, can you fix it with the electronic health record? Where is that? What about the patient? When I go into my electronic health record, A, it takes me 20 minutes to log on because I can never remember the circumstances, the passwords. But B, what is it telling me? It gave me a test result and that's it? Why isn't it helping me navigate my health? Why isn't it telling me what I should be thinking about, what I should be asking? There needs to be a service element to patients in electronic health records. It should be on my phone. Right? I should have my phone sending me health record alerts saying, Mike, you're a certain age and you need to do this in the next 3 months. Here in this vicinity are 17 highly rated practitioners who provide colonoscopies. Right? Click one for more information. Where is that? Right? We do it for other stuff, silly stuff, but we're not doing it for important stuff. So I would like to see electronic health records actually turn into a legitimate pillar of healthcare quality. Not just a billing aid, not just something that is there because it's attached to this, that, or the other. And we're close. Pharmacy computers are great. We're pulling data directly from them. Laboratory computers are marvelous. We're pulling directly from those as well. Within the next year or two, we will have a national map of antibiotic use and resistance of organisms and be able to put them together and add them to those targeted reports so that we can say, hi, did you realize that on your pediatrics ward, you have a huge rate of this resistant organism and you're way overusing this one drug? Can we help you come up with a better approach? So there are ways that IT technology, redundant, health information technology can help us. And I think we need to go in that direction. So thank you for your kind attention and for allowing me to be here today.